Could I invite all our speakers to come to the front and sit in these chairs? One of them is broken, but I'm not going to tell them which one until we think we fixed it. I'm going to turn this off, I think. I'm not telling you. Yeah, it is that. It's okay, we fixed it.
There's only one left.
Okay, yeah, I'm going to find out. It's not really. Good. So, so I have a lot of questions, but it's really the audience's time now. So if you could put your hands up if you have questions for our panelists. Just wait for a second. And I'll move around and give you the microphone. So hang on, I think we were first here.
Hi.
Hi, here you go.
Oh gosh. Hello. I'm not really sure how to phrase the question, but it was more of a thought. A problem that I've encountered personally with experiencing not treatment in terms of medication, but in terms of mental health treatment has been feeling a bit erased in terms of my gender identity. And I've seen some mental health professionals who have never actually come across people who don't fall in the gender binary. Yeah. And I've come across it at least probably 5 times over the last 5 years, and I find it quite astonishing, really. I identify as non-binary, and I've been called kind of unusual or all kinds of things, and I think it's been mainly mental health nurses, but they've kind of talked to me through that kind of binary lens, and I found it quite difficult, and it's definitely had a poor effect on my mental health. But I know it was, you know, the topics were relating to medication and kind of biological differences, but I was wondering if anyone had things to say on that. I don't know, it was just a thought that popped in my head, yeah.
I can say one thing, which is I think that the evidence base just simply isn't there. That's, I think, partly why there's a challenge here. Is that it's a phenomenon which is changing in cultures and societies rapidly across time, and we haven't really caught up. So all the therapeutics, all the evidence, is based on usual male-female, men-women. I mean, male-female is often the term used as though we're lab rats. I mean, that's just a...
Yeah, I think most people have difficulty even understanding that there might be genders as opposed to, you know, kind of at the most think of a 2 or 3, and then people, I think professionals find it increasingly very difficult to get their heads around a lot of this. And you know, I know a wonderful project which in India is going around actually educating professionals on understanding gender and sexuality in a much more broader sense rather than just this kind of binary way of thinking about gender. So I think there's need to actually get professionals, especially health professionals, to understand these differences.
Absolutely, because it can be quite alienating for people who think, you know, kind of, what about me?
Yeah.
Thank you.
Thank you. Firstly, thank you for some really wonderful papers. I enjoyed it enormously. And my question is, I suppose, initially to Martin, but then to the others as well, which is, as a historian of emotion, I'm interested in how we take a diagnosis like depression and how we track it and how we compare it and how we do any sort of longitudinal work at all. So when we're looking at all the different variables involved, how do we know what people are talking about in different contexts, whether across time or cultures, with using something like depression? And I suppose linked to that is this relationship with mind and body. So we talk about mental health all the time, and yet so much of this is embodied and articulated through the body. And I was wondering how that broader perspective on the language used connects to these papers.
I can say very briefly that we thought long and hard about how to measure it and how to conceptualize it. So the actual scale that we used was validated within India, for example, the DAS. But that itself had its limitations and its problems, because people answered questions particularly in ways which were culturally framed and culturally bound. And we had to guard against their respondents giving responses which they thought that the interviewers wanted. And we had particular dynamics going on. So the capacity building project was training students to become researchers, and the researchers were training students in some of the techniques of research. So we had students who were collecting data supervised by faculty members. And there was a big age dynamic going on as well. So people were giving particular responses. So we had to treat some of the data with caution and maybe indicative. I think what you're also referring to is thinking about the connection of mind and body and mental and physical health. So we can look at it on one level as the interrelationship between risk factors and how you cannot treat one without the other, and we are complex human beings and both interact on each other. In India, particularly where mental health is stigmatized, people don't recognize it, don't want to recognize it, or if it is recognized within the family, it can be suppressed, it can be hidden, or not given a priority as a physical health condition might be. I think the economics of some of the dynamics of treatment are quite important. So within a family context, again, it might be certain members in the family who might be favoured for treatment, and that might be a more of what is recognised and more of a socially acceptable physical treatment than perhaps for something which might look like depression. But we know that our understanding of depression, a Western understanding, can be quite different from in different parts in the world. I don't have a quick and easy answer to you because I think that it is incredibly complex and we're learning.
If I can add, I would say that mental health issues, brain diseases and mental ones are stigmatized, a bit overlooked. So I wouldn't emphasize on India. I think we're still far from where we should be. And when we think about the future and how we should maybe solve the problem of how a behavioral symptoms might correlate with pathology either in the brain or our body and the way it's influenced, the solution might be the digital future, where the scales that we usually use at the moment, where there is a problem of inter-rater variability and intra-rater variability, might be overtaken by the fact that digital ones will not be biased by the assessor, and there are also evidences pointing to the fact that when we have, whether we like it or not, this can be discussed, but when we have an interface like a computer or a technological device, we are more prone to share. So it's very well known that suicidal thoughts are very often shared with a computer rather than with your mother or your beloved ones, right? So I think that especially in mental health and in neurological disorder, digitalization might be really the much needed solution for optimizing the clinical trial development and also monitoring how we respond to drugs, preventing suicidal attempts, etc.
Can I just add to that a little bit? I think it's interesting, but in many cultures and in many languages, there is no equivalent word for depression. And so does that mean depression doesn't exist? Of course not, it does exist, but it's not conceptualized in that kind of diagnostic categorical way that Western biomedicine tries to categorize it. So in India, for example, if you try to talk about depression to people, they don't really get it. And in all our work, increasingly, that's why we don't take a diagnostic approach, but take a very trans-diagnostic approach. Clearly, people are distressed and people have mental health issues, and there are ways of expressing that distress. And there is a language for it in their own cultures. And I think what you need is, rather than try to go in with these square pegs and try to fit these into these round holes, it might be a good idea to actually start with the round holes and say, okay, how do we structure a world and understand a world we're using these round holes? So we do a lot of our work. We don't do diagnostics at all. We take a trans-diagnostic approach and saying we're going to deal with distress and functional impairment, the things that matter to people's lives. diagnosis does not matter to people's lives. What matters to them is distress, what matters to them is functionality, what matters to them is what do they do with their lives. And if you take that approach, that's different. I think the diagnostic approach is largely driven, and this kind of a single disease, single disorder, condition issue is largely to do with the need for development of drug therapeutics and all, which requires these kind of homogeneous categories, whereas cultures really don't need those kind of homogeneous categories of distress. So I think we need to really look at it slightly differently than just think about this from a purely, narrowly health, physical, biomedical health perspective. Yeah.
Thank you. Next question.
Just a general question with regards to pharma and pharma industry and Roche, perhaps. How does mental health research and drugs and diagnostics, the funding that's allocated for those activities compared to the other, perhaps more?
Well, I have to say that the funds allocated to neuroscience, and this is not only pharma, this is in general, when we compare to what gets allocated to oncology, is really little. And this is a matter of concern. I would say that nevertheless, neurological and mental diseases are still a big unmet need, and this is where also pharma companies are very much aware. So they are prone to invest and to find solutions because there is a huge unmet need. And this is not only, this is my personal opinion, it's not only about drugs, but it's also diagnostic. I was working in a hospital for 6 years, and I was so frustrated of not being really able to diagnose my patients with a certain type of disease. It was always clinically possible in dementia of Alzheimer's type. Translated now in English, I was working in a German setting. And I very much believe that we should shorten the time to arrive to a very precise diagnosis, as much as we do with oncology. So in my understanding, the developers are really willing to explore this pathway because it is still uncontaminated in a way. So there is a lot of opportunity of having also returns in terms of optimizing treatment, diagnosis for patients, and also then what is their business model, which has to be nevertheless sustainable, right?
So I think it raises a really important question about investment into research and the balance of investment. And recently the Alzheimer's Society have had an exercise where they've tried to look at what might be the research roadmap that you would balance, as it were, the investments. There's been $500 million promised in a public-private set of partnerships to specific dementia-type research, Alzheimer's, and mechanistic research and drug discovery. And it's not balanced in any way by an investment, by a similar investment, which would be capacity building and expertise, interdisciplinary research, social, ranging right the way through all the different disciplines required. And we're working really hard to try and bring that up, but it's very hard because it's not as attractive. And the fact is that the trials to date in Alzheimer's and mild cognitive impairment and depression drugs, you can talk about perhaps the medication because that's also a difficulty in terms of recruitment. But for dementias, the age groups and the representation of the types of people who actually get dementia and are the societal concern, they don't map well. So when we do have drugs, they will probably work for very specific groups, and that'll be brilliant for those people. It'll be marvellous, as long as there aren't horrible side effects. But for complex, frail, older people who are nearing the end of life, because that's where a lot of dementia happens, that approach will have to be much more nuanced about our approaches. So I think it's a really, really good question.
Anyone else? Oh.
I don't have a question. Are we still broadcasted?
I'm sorry?
Are we still
I think we are, right?
Yes.
Yeah. Let's assume we are. till we find out differently. Nobody make any rude comments.
There are a huge number of complex issues, both in the problem and the possible solutions to global mental health problems. I was wondering if any of you wanted to mention any potential low-hanging fruit that still remain for progress in mental health policy and research. Things like friendship benches, things like banning the most toxic pesticides to reduce suicide, and other areas that have been traditionally neglected.
I don't like the term global mental health for various reasons, but leaving that aside, I mean, I won't get into that for now, but coming to your point, which is about what can we do globally to try and improve mental health for populations. And I think some of the things that you suggested are very appropriate, and Friendship Bench especially is a good example of a great innovation which started off in a low and middle income country, is now moving to a high income country and is seen as being something that is applicable. So this was something that was developed in Zimbabwe and is now being copied in New York. And so that's an amazing example of how innovation actually can work both ways. It's not always innovation has to move from high income to low income country. And we have a similar thing that we've developed in India, which we are just in the process of reporting. I think while there are commonalities of what we should be doing across the world, I think it's very important that those interventions and treatments are actually culturally appropriate and have some sense of a bottom-up approach to developing them. Otherwise, you start getting this kind of imposition of treatments, which I think is a problem. I don't think that you said low-hanging fruit and you gave a lot of examples. I don't think those are low-hanging fruit either. You know, getting a ban on toxic pesticides is not an easy job. It's easy maybe in Sri Lanka because of Sri Lanka's specific geographical status of it being an island, not having any pesticide producers in its own country. It's easy. Try doing that in India. It's close to impossible. Because we are the hub of pesticide manufacturing, and we are not an island in that sense, and so controlling this would be very difficult. So I think there are a lot of geographical and political and social realities in trying to implement solutions for mental health issues. And I think we need to keep that complexity in mind when we try to do that, firstly. And secondly, it's not a one-size-fits-all thing, so that needs to also be taken into account. I mean, I could go on and on, but I'm going to stop. I'm happy to kind of have a back and forth if you want. But
if I may add just a thought that I had, I'm not sure it's a low-hanging fruit, but something that is happening and we should capitalize on is again the technology, having simply Google there. So some doctors hate it, that people just check for their symptoms and they get a diagnosis on Google. On the other hand, I think that this is empowering people. And I think one way in the future to improve mental health will be to empower, especially young individuals, to get right information, to know what's happening to them, to know what they can do to improve their own health. And so this is something that can be done with awareness campaigns and with proper information on the internet. So my thinking is that empowering each individual via the technology that is available is actually a very viable way that could be implemented.
I have two suggestions. Again, probably not low-hanging fruit. Anti-stigma campaigns, international, they are in many, many countries, but those need to be done and rolled out continuously. And that needs to be brought into training of practitioners. Mental health literacy across the health and social care professions is absolutely essential. And within that, about respecting the needs of individual people, looking at people as individuals.
But I actually had a comment regarding the stigma.
Yeah.
It relates to what you mentioned. I don't know if you see where I'm going, but you rightly said that it might be important to shift the focus from the health issue of mental health towards the human rights. And I totally see the reasoning and the point. At the same time, I very simply think that to remove stigma, the easier way would be to say that mental health issues or conditions are a disease of the brain, the same way we can break our we can break some synapses and we lose the function of the brain. So part of me thinks that pushing it as a health issue is the way to remove stigma, because then you're not ashamed of breaking your leg. Why should you be ashamed of having depression, you know? Well, but then it might be cultural as well. So I don't know.
No, it's not cultural. Well, it's an interesting thing. We all thought that, if you had a biomedical explanation for mental health, that would reduce stigma, because it would take away this notion of you are responsible for it. But the research is actually completely different. People who believe in a biomedical perspective on mental health, that it's an illness, exhibit higher rates of stigma. Stigma is more when people believe a biomedical cause for mental health. So it's not a very straightforward relationship. By making it a very biomedical health condition, we will reduce stigma. And the other issue is, I'm kind of not a fan of stigma, anti-stigma work. If you look at stigma research, there's been tons and tons of stigma research now, and the only anti-stigma measure which has worked across studies and across years is contact with people with mental health problems. Okay, that's the only thing we know reduces stigma. I mean, Time to Change in the UK has invested a huge amount of money and has brought about very little reductions in people's attitudes towards mental illness. I mean, I know they say, 9%, but I mean, 9% is not a huge number. In fact, what we need to really do is, I think as human beings, we'll never stop stigmatizing someone or the other. And so stigma is really going to be with us for the rest of humanity, in a sense. What we need to really focus on, and that's something I believe very strongly, is focus on discrimination. And that we should focus on removing discrimination because it impacts people's lives directly. And secondly, it's measurable. It's behavioral, it's measurable, it's amenable to policy action. Whereas stigma is in your head, and you can't really get it out of people's heads. And in fact, paradoxically, if you reduce discrimination, you would see that people have much more contact with people with mental health problems, and you would actually reduce stigma. So I think it's not about reducing stigma to reduce discrimination. I think it's about reducing discrimination to reduce stigma is probably the way forward, because discrimination is something that's behavioral and measurable. I think you're welcome to think what you think about your neighbor, but your neighbor has a right to be there as much as you do, however they look, whatever they are, whoever they are. And I think that's the message we should get across with the whole stigma issue. And the word stigma and discrimination gets used, as if they're brother. It's in one sentence, stigma and discrimination. They're not. We need to focus only on discrimination.
Although I think, if I can bring another perspective, at least in the Western society, there was a lot of stigma around cancer a few years ago. Nobody wanted to share their cancer diagnosis, right? I mean, it was quite a stigmatized condition. By improving the way we treat this medical condition, by the way we diagnose it, improving the diagnosis, I think we have removed a lot of stigma. And now to talk about cancer, it is just, first of all, it is
but you didn't have discrimination,
but
you see.
Also,
but you didn't have discrimination.
By improving diagnosis, I think you remove the stigma, and whether then it goes around with discrimination, well, I am not an expert on this, but I think that one way to remove both, most likely, stigma and discrimination. It is really to do all we can to improve care, to improve diagnosis, and to share eventually.
Well, we have institutionalized structural discrimination about people with mental health problems across societies, which you didn't have for cancer maybe. And that, unless you tackle that kind of institutionalized thing that is done, you're not going to get rid of stigma. You can tell me anything, I should accept my mental health problem. But in India, if I accept my mental health problem, that could mean that I might lose, my spouse has a right to then divorce me, and I might lose control over my children. Then it's all very well to accept your diagnosis. I suffer serious loss if I were to accept that diagnosis. You're not going to go away unless you remove this institutionalized discrimination. You're not going to get people saying, I have a depression. I mean, why would I say I have depression if I could lose my children? I'm not going to say that. So I think with cancer, maybe we never had that institutionalized discrimination.
Exactly. But I think it also goes down with cultural differences and the societal setting, because I think there are societies where we are much more advanced. I mean, if I think of North European countries, for example, this type of institutionalized separation for mental and brain diseases is already gone since quite a while. So I think it's, we have to try to progress and learn from those who are doing better.
I think we're going to wrap it up. Carol just had one last, you're the last speaker, maybe you get the last say in this discussion.
Well, I was going to say something different. I was going to say something which wasn't related to that last point, but was about the concern about medicalisation and quantification, the quantified self, and maybe there are some, I think there are some sections of society, particularly in high-income countries, where, and possibly the rich in lower middle-income countries, who do embrace the idea of the quantified self and everything being tracked, and actually you have your wearable on you. And there are others, though. There are others, and I think the marginalised and the lower, people in poverty and so on. The concept of it all being done in a quantified self way probably is very alien. And there's another group, possibly, or mixtures of these, who think that the picture that you portray is a bit. There's a book by David Egger called The Circle. It's a kind of dystopian future where we aren't really people. This is the whole discussion about the boundary between humans and machines, I think. And I think it is something we really, really need to. We need social scientists and historians and cultural analysts to understand what it means for us as what this means for us as humans. It's just not an automatic good.
We need philosophers, we need ethicists.
Yeah, absolutely, and law and the whole gamut.
Thank you. It's been a fantastic discussion. Could you join me in thanking all our speakers once again for that?
Thank you.